Hello, Roxana and Holger, everybody. Welcome to the first live case of day 3 of TIO. And we'll be doing 2 live cases in parallel from the Erasmus Medical Center. One is a coronary case that will demonstrate new software technology to introduce coronary physiology in the lab. And the other one is a TAVI case. And I'm going to present first the TAVI case, and after 10 minutes or so, we will switch to the other room. But we'll have quite a fast pace, as you will notice. So I'm doing this case, which is a lean TAVI case. That is the topic, the focus of this case. And basically, it's a natural maturation of our TAVI program, which has a heavy involvement of research fellows, but also our nursing staff and technical staff. So I will be doing the case with my head nurse, Linda Josias, who is standing next to me, and Mario de Ronde, who is in a PhD program from a nursing background. And then there's also Huda, another nurse who is taking care of the patient while we are doing this procedure under local anesthesia. And then technical support from Liane and Tommy, TT. The patient that we're going to treat today is the following. It's an 86-year-old male who had a past medical history of cabbage a long time ago. Diabetes, renal impairment, and then he presented a couple of months ago to the referring cardiologist with progressive shortness of breath and then also a syncope. During the workup, they diagnosed, next slide, severe aortic stenosis with, on his EKG, some arguments for left ventricular hypertrophy, but a small QRS complex. These were his coronary patent grafts, and this was his echo. So it confirmed a hypertrophic left ventricle, severely calcified aortic stenosis, and a preserved ejection fraction. Next slide. So for the CT scan, I have Daemen, who is one of my research fellows, and he will discuss the findings there that helped us planning this case. Daemen.
All right. In the left upper corner here, you can see the annulus which has of the aortic valve, which has a diameter of 22.7. There are no calcifications in the LVRT, but the aortic valve itself is moderately calcified with a height of the ostium of the left carotis of 14.7 millimeters. If you go to the femoral for the access site, we scroll down from the aortic valve through the aorta. We see some calcifications with some severe calcifications in the aortic abdomen. However, there are no calcifications in the femorals, although we see some tortuosity. The smallest diameter right is 6.7 and left 8.4. And last, we go to the subclavian view for embolic protection. The patient has a normal anatomy with no calcifications in the truncus brachiocephalica and in the left coronary artery, so that's eligible for embolic protection. Back to Nicolas.
Okay, so in the next slide, we'll summarize the heart team discussion. Basically, we're dealing with an 86-year-old male with his history of cabbage, but already based on his age by itself, we easily got a consensus that TAVI should be the treatment of first choice for this patient. And within our program, we have a use of embolic filter protection in all our cases, at least if it's anatomically feasible, and that is the case in this particular patient. Why do we call this lean TAVI? Well, first of all, we do believe that embolic protection should be part of it, because by using cerebral embolic protection in elderly patients, one of our other centers in the Netherlands, from Utrecht, they demonstrated less delirium after the procedure. Also, by reducing anesthesia protocols, so only using local anesthesia, the likelihood of developing delirium is smaller. So we are getting our patients, or we are preparing our patients for early discharge protocols. And Mario is doing a PhD on this topic, where we are discharging our patients either home or to the referral hospital. So this patient will go to the referral hospital tomorrow morning and then have the weekend to chill out and then go home on Monday. But at least the patient will be out of our hands, at least out of the hospital by tomorrow morning, which opens up, of course, opportunities for other patients. And that was one of the reasons why during the COVID-19 pandemic, our TAVI program was not affected. We just kept on going because we were not using the resources that were necessary to provide COVID care. So we don't use ICU care, we don't use anesthesiologists. So this lean TAVI program really facilitated the TAVI program. And we all know that postponing procedures in patients with severe symptomatic aortic stenosis will come with an increased mortality on the waiting list. So with that, are there any questions from the panel or from the chairs?
Presentation. Nick, just go for the procedure. I think it's a perfect presentation, and it's relatively clear what you want to do. I think just go on.
Yeah. Okay, so what have we done offline? We put in a radial sheet for the sentinel, and we put in a 6 French femoral sheet. So we will only use a right femoral access. So we don't matter for the left side. So we have a pigtail in the superficial femoral artery, and we will go for a large bore access in the common femoral artery. And I'll demonstrate this with echo guidance, which is a technique that I believe is absolutely mandatory when you are doing large bore procedures. And here you already see that there is a sheath in place, and you see the bifurcation in the long axis. And then when I counterclock rotate, then I get short axis. So short axis, and this is a very important view. This is the Mickey Mouse view, and you can see the head of the mouse. You have the right ear, and then the left ear wearing an earring, and the earring is, of course, the sheet for the pigtail later on. So now I'm going to advance my probe more cranial, and I jump into the common femoral artery. And so here we are in the common femoral artery. This is a nice position, a nice location for the arteriotomy. I don't see any calcium. I do see the catheter, the sheet already in place for the pigtail. So I'm going to give some local anesthetics to the patient. Klein prikje, meneer. And the patient, he is following the procedure. He's very relaxed, and he is... He has a separate screen so that he can follow also the procedure. So and basically we try to... No, zero. And we believe that that's very important to monitor our patients.
Is there an anesthetist in the hybrid OR or the cath lab?
No. So there's no anesthesiologist here. And here you could already see that I accessed the vessel, and I remained on top of that other sheet. So I don't want to perforate that sheet because that already carries my pigtail. So we do have an anesthesiologist who would be available within 2 minutes. So because our cath lab is in the OR protocol. So that was access. So now we have our access. We will later on upgrade to the 14 French E-sheet, but now we're going to introduce our Sentinel filter. The patient receives 5,000 units of heparin. I'm not so liberal with heparin anymore because the procedures are so fast. So let's bring on the filters. And then after the filter is in, I would suggest to then transition to the next room where Joost is waiting. So we have 2 more minutes. That is plenty in principle for a filter. So Mario is...
Just one further... Can you hear me? So just one further question. Did you inject any contrast dye into the 6 French arterial sheath just to look for how the femoral artery looks like? Or is it only by ultrasound?
Yeah, so of course we have our pre-procedural CT scan and then ultrasound. Only in obese patients I will do a confirmatory angio. because sometimes in very obese it can be tricky, even despite using ultrasound. So sometimes you end up at the bifurcation or below the bifurcation while you were aiming for the common femoral. So that is definitely worthwhile to confirm. But in this particular case, this patient is as a normal habitus. There's no problem to, and then we avoid the additional contrast. Okay, so, oops, sorry. So here we are in the subclavian artery in the brachiocephalic trunk already. And Linda is manipulating the wire, the coronary wire that precedes the filter. And then we have in our pre-procedural planning schedule an LAO 30 view that will open up the bifurcation, so the origin of the brachiocephalic trunk. Meneer Van Houwelingen, adem is heel diep in. So now I ask the patient to breathe in. And then Linda is advancing the wire. En pull the wire. En rustig ademen. En nog eens diep inademen. Diep, 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 diep. Heel goed. Ja, ja, go. Nee. Okay, so I prefer to have my my filter in the ascending aorta. Well, in this particular case, it doesn't do that. It's no worries. So then we'll deploy the proximal filter. And now we're going to try to deploy the distal one. Oops. So let's pull on the pigtail a little bit. Okay, Linda. Advance the wire. Okay. Een beetje wachten, terug. So as I am getting aligned with the common carotid, Linda is now going to advance the wire, and we're still not good, and advance again. No, it's a huge brachiocephalic trunk. Huh? Yeah, there you go. Our little fellow jumped in. So we know that there is some tortuosity in the left common carotid. And here we are. So our filters are in. So the brain is protected. At least 3 of the 4 vessels to the brain are protected now. And this is basically, in contemporary practice, the best you can get at this point. And I do believe that eventually we'll have to strive for complete protection. That said, this is the first demonstration, so we'll be ready in 10 minutes. I mean, our case will be complete in 10 minutes, but I would suggest that you briefly go then to Joost. He can then introduce his case, and then after his introduction, we come back and close this, and then I'll come back to join you. Is that a plan?
Don't finish the procedure before we get there.
Perfect plan.
Okay, see you later.
All right, well, good. Don't forget, don't finish the procedure before we come back to you. All right, well, here we are. Joost, you're on. Please introduce your case. Welcome.
Hi, welcome to Rotterdam again, this time another room. So we've got quite a challenging case for you today. We're here in room 26 together with Peggy and Sanna as nurses. My friend and colleague Wijnand den Dekker is with us, and today we are supported by Jurgen Lichthart, well known as the invasive imaging specialist from our site, with experience from on day 1 of IVIS. And then there is Kanashka Masjedi, who is one of our fellows with a specific focus on angio-based FFR, as this case will be all about. So Wijnand, why don't you present the case?
Yes, thank you very much. Can I have the slides on the screen, please? Can I?
Yeah.
Well, I'm sorry for this.
The slides
okay.
are up. Okay.
So this is a 52-year-old male patient that had no relevant history until the beginning of the month, when he experienced STEMI inferior, and that was in another hospital somewhere in the north of the Netherlands. And there they treated the right coronary artery, and then there were some residual lesions in the LAD and in the circumflex. And then they decided just to treat the right, and discuss him in the heart team for the non-corporate lesions in the LAD and the circumflex.
So can you see our slides, Roxana, on the with the angiogram?
Well. Yes, we see it very well.
Now we see
it. That's
okay,
great.
so we don't really know what you already see, but now you see the left coronary system, and you see that there is still a lesion in the mid-LAD, bifurcation with the diagonal, and also a lesion in the MO branch of the circumflex. And the next slide. So on echocardiography, he had a normal left ventricular function. Next slide. So he was brought up in the heart team because of the residual two-vessel disease. He is non-diabetic. He has a preserved left ventricular function and a good renal function. And the residual syntax score was 19. And furthermore, his BMI is quite on the high side. It's 41. So in a discussion with the surgeon, it was decided to do a PCI of the MO branch and LAD. Next slide. So I'll give it to you back.
So interestingly, the patient was referred by an ex-colleague who actually referred to him as being somebody who lives in our neighborhood. He was treated in another site, not a bit more distant from here. And he's asymptomatic at the moment. So that is maybe in the light of the presentations of just a few minutes ago, interesting. But he actually was discussed and accepted for a repeat angio with potential physiological evaluation. I mean, you all remember the data from FAME telling us that lesions like this, like in the circ, might be FFR negative in 20% of the cases. But in this case, the lesions looked at least angiographically quite tight. So the idea of today would be to do a recap, which we just did, and then do an online live demonstration of the CAS VFFR 3D QCA-based software that we've had the privilege to extensively test in Erasmus in the past 2 years, and then obviously upscale to pressure wire-based FFR or HDIVs in case. Any questions thus far?
Good case, and I think for me, I look at for complete revascularization in this man, based on the complete trial. As you all know, that this patient should have complete revascularization for the hard endpoint of reducing death and a myocardial infarction. The question is, which one of these lesions require revascularization, and if you should know that in complete, that was not assessed by using FFR or QCA or what have you. It was the physician's discretion to perform full, complete revascularization. So I think it's a very, very good case. I want to go to Ajay, and ask him about the assessment using QFFR. And here they're hoping to still do an invasive FFR. We're seeing a lot of these non-invasive approaches. In fact, it's actually impinging on some reimbursement issues in our country. And maybe Ajay could just give us a little bit of a sort of an input. And would you proceed, and do you use QFFR?
There are actually several systems of doing an angiography-based FFR. There's obviously a CT-based one, which is HeartFlow, and in the cath lab, there are online systems, which is why I think the demonstration will be really nice to see it online. But I know Joost wants to show it really quickly. These have been validated with respect to invasive measurements, and so it seems like it's reasonable to use. The only way to tell that is in a randomized way, and that's actually being done in a very, very large number of thousands of patients in China right now. With this specific system, the METIS system, angiography-based versus QFR-based with clinical outcomes. So that's the type of study we really need to see to determine if we can make differences.
Yeah, exactly. So show us what you're going to do.
Important to notice. Yeah, so important important detail, this is not QFR. So as you know, there are 3 systems on the market now, which is the CatWorks, with FFR Angio. There is QFR, which is definitely the one that has been most widely studied. QFR, that's the METIS software you're alluding to, which is also being used in the FAVOR 3 trial. But what we are going to show you is the P-medical version, which is called VFFR. V stands for vessel FFR. It uses a more or less similar approach, but we will show that to you live at this point in time. So this is actually the first time we do this live. We do use it sometimes for research purposes, but I have not been using it in routine practice. So what we did is we shot a angio of the right just to confirm the patency of the right. You can see that here, and showing you a nice result after stenting of the distal right. And then we confirmed the lesions on the left side with a tight lesion in the proximal part of the OM branch, some disease already visible in the LAD. And then this is the caudal projection also here, showing you a tight lesion in the obtuse marginal branch. And then we continued with the LAD projection, so cranial projection here, showing you a long lesion in the LAD, ranging from the proximal part to distal, and also in the RSO projection, nicely appreciable. So what we want to show you is how we do VFFR live. So what we did is we just stored these angios, and I'm going to pass the word to Ken to show you a live demonstration of the VFFR of the obtuse marginal branch. So Ken.
Can you hear me? I don't have content. Okay. Okay, hello
okay,
everyone.
Ken, you're on.
I would like to start with some general comments about the quality of the projection we use for the VFFR calculation. So first of all, it's very important to start the procedure with intracoronary nitro to avoid some coronary spasm, and to optimize the flow by avoiding the coronary spasm. And this is the first step. And then for the operator, it's very important to realize and to take into account to avoid foreshortening and overlapping, since we use the angiography for 3D reconstruction of the vessel, included the lumen of the vessel as well. So here we have the first projection which we will use for the 3D reconstruction. That is the right superior, and we import this to the software. And the second projection we have is the caudal projection, which is unfortunately not optimal due to the weight of the patient, but we can use it. So first thing we have to do is to be sure that the both angios, both projections in which we do the contour detection are in the same phase of the cardiac cycle. So the software gives us the red, the green points, which are similar in both projections. So you can use these points, but if you replace the white point, you should do the same with the second projection as well. So in this case, we will use this image, cardiac phase, and this is comparable with the third green point at the right side. So we start with the contour detection, automatic contour detection of the first projection. And very important not to forget is to ask the clinician, the operator, where he wants to measure the FFR. So how far should I go with tracing? So my question to Joost is, where would you measure FFR if you would use a pressure wire FFR?
Yeah, so in this case, Ken, I would go until the bifurcation with a small posterolateral branch distal in the OM.
It's very important because the depth of the tracing will have influence on the number you will get. So this is the first projection, and Joost. So we have to do some manual correction of the contour detection. And here.
So the accuracy also obviously depends on the quality of the angiogram. In this case, the BMI of 43, which was unfortunately not in the referral letter.
So now we've got
that this morning, did not help.
We traced one projection, and now we go to the next one, and it's important to trace until the same level as the first one, and this is here. And then we go with the red points to the place where we think the stenosis is. In this case, this is a little bit diffuse with the most severe stenosis in the middle part of the tracing. And then, so this is a 3D reconstruction, as you can see right below. And this is for the geometry of the vessel. And then we need some hemodynamic parameters as an input for the software. This is the blood pressure at the beginning of the procedure, which we already noticed. This is 100 above 74. And just click on the bottom and you will get the FFR value. This is in this case 75 with a delta of pressure proximal from the stenosis as compared to distal. And then you can also walk around this vessel with a marker and you can see a pullback of the vessel. In each point of the tracing part you can see the FFR value. Also left below you see a curve. This is also a
okay, thank you, Ken.
pullback.
So I think with this, you can see that with this software, within just a few clicks, and obviously now we took the time to elaborate on the need for the two basic conditions, two orthogonal projections with minimal foreshortening, minimal overlap, and the second prerequisite, you record the aortic pressure undampened at the time you do the angio. Those two inputs you need for the software. And then within actually a few minutes, you get your VFFR. So this value is interesting, because we know from the Fast Extend trial in which we assessed this software in over 300 cases that the 75 is below the threshold of the gray zone, which we identified to be between 80 and 85, with a sensitivity and specificity of around 95%. So 75 is definitely below. And in this case, in the zone where we are pretty much, of course, 100% is utopia, but pretty much sure that this will correlate to a positive FFR in practice. So maybe question to the panel: if you see this, would you be convinced to continue with stenting, or would you like us to do a pressure Meyer-based FFR just to confirm?
I personally would have stented without any of this, because it's a 90% blockage and a major OM. Sorry, but that's what I would have done. You're much more scientific than me.
I mean, I think what you would have done is what most people in the world would have done. We know that 21% of the people in Europe at least uses FFR. But still, we are surprised now and then, specifically in these right or circumflex branches. But in this case, I agree, the lesion looked angiographically quite tight. So just to confirm, we did a pressure wire-based FFR just to show you the correlation. So maybe Jürgen or Martin, we can briefly show that.
Yeah, and the coroventus.
So what is before you show us what it is, what do you guys think? Before you show us the number,
the dimension.
David, what's the FFR? What's the FFR number?
Well,
I'm
okay,
going
so
for 0.69.
2 points. I go for 0.80, but I also wanted to ask: did I hear correctly that he has no symptoms since he had his heart attack?
That's correct.
Yes.
That's correct.
Okay, so the indication for the angioplasty is what?
Multivessel disease, which is so this is a very interesting point, and I mean Roxana already pointed to the complete results. That is correct, but incomplete.
But the complete
most
study
patients were
is
just
not in this
based
setting.
on.
This is not...
No, actually it is.
Why not?
Unless I got it
Why
wrong,
not?
guys. I'm sorry. I think this is a complete patient. If you did the angiogram and at the time of STEMI to the staged PCI for the multivessel intervention was somewhere between 45 days of the STEMI, that is a patient who belongs in the complete study. So this is a complete patient.
And the vast majority of these cases were not reassessed with FFR or ischemia testing.
Yeah, because they were included just when they came back to the CCU, so just right after the STEMI they were included.
So what was the pressure wire?
I think only a certain proportion of them were delayed to this extent.
Yeah, Yeah, so we will just tell you, so the FFR was 68 or 67, which was indeed positive, as most of us would have anticipated. So we briefly proceeded with an IVUS in this case because the lesion is quite long. Maybe just short question to the panel: who would use IVUS in this case?
We would. I think, especially for optimization purposes and to be sure you've gotten it right. But we talked a little bit about that yesterday. You know, the one thing about doing the invasive ischemic assessment or ischemic assessment period is that by complete you wouldn't do it. But to David's point, if you're concerned because the patient's completely asymptomatic and you absolutely want to prove it, then it's fine to do. And I think that's, you know, one of the reasons I'm sure Joost picked this case to demonstrate. The challenge is if you were thinking you were going to do it, and then you have a negative result, then you're in a conundrum. And for all clinicians, it's important to always assess what's going to happen with what you do based upon positive and negative results of a test.
Yeah, that's definitely true. And of course, the more you measure in multiple ways, the more discrepant findings you will get. But in this case, I mean, it's severe disease with in this case, a test that is well validated that is positive. So I think with this, we are definitely justified to treat this case. So to me, I'll let you briefly show the IVUS, then we'll proceed, and then maybe you can switch again to Nicolas's room. So we did an IVUS here, and why I asked who would use IVUS, and in this case, I would, I mean, you see there are two key things. One is the issue that there is this lesion which virtually starts at the ostium with the posterolateral branch, and the fact that this lesion is potentially longer than we anticipated based on the angio. So what we want to know is, do we need to stand across the ostium of the PL branch? Do we need to start distally? Is there a landing zone? What is the diameter, etc.? So maybe Jürgen briefly walk us through the IVUS.
Joost,
before we let you go to the other
everyone
room.
consents what to treat, then let's see how to treat. So we were in luck in the distal portion because we have almost a normal vessel in here. So then this would be a nice landing zone. Already we know there that we need a 3.0 stent. Then to see, because we're going to need 2 stents, I go slowly with you proximal. You see immediately that the vessel gets a plaque, fatty fiber calcific plaque at 7 o'clock. If we go further, we see this second lesion. You have a little tandem lesion, what you could appreciate on the angiogram. The second lesion is was here. We have a bit better landing zone in here, and then the real tight one we get in here, and even here we have some organized thrombus, some mixed plaque fibers, fiber fatty material, and the IVUS catheter barely fits in. And then we get at the ostium of the MO, and this is a nice landing zone also. So if we have the total length from where we want to have the stents, then we are at more than 40 millimeters, so we will need 2 stents. And in the discussion before, Joost said, well, I want to do a 23 millimeter stent distal, but actually I changed a little bit because you want to have a nice landing zone proximal. So that's why I made some measurements here. And with 18 millimeters, we land exactly in a spot between the 2 lesions. With 23, we end up in this lesion here, and that's asking for nasty dissections and so on. And you definitely don't want to have an overlapping stent in there. So I was so free to think, well, this is a nice landing zone proximal. We can here let stents overlap. So if we have a 3.0, 18 for distal portion, and if we look proximal, we have a lumen of 3.5 here, and actually probably people will think, well, why don't you go media to media? Now what I like, I always go for the lumen and then I add something. So if we take a 3.5 stent in here, we have exact good lumen in here with a well-opposed stent and a good treated vessel. Remember, we always need to have some room for the plaque there.
Even if you would use a 38, would that do? Would that cover the lesion?
I'm afraid not, Joost. I think that, they put it already in the room because I was thinking here. Yeah, at 43, you need 43. So I would go for the 18 and the 24.
Okay, then let's do that.
The 3. And for your orientation, you land this 18 at the proximal landing zone. You land just after the first tight stenosis, so in between.
Okay. All right. Comments, questions?
We'd like to go. I mean, no, I think this is a great demonstration of how much IVUS is helping to optimize the results. But maybe we should go back to Nicolas before he finishes the lean TAVI.
Sure, do that.
Yeah.
Yeah, let's do that. He must have been finished by now, knowing him. But go quickly back, and then we'll see you back in a bit.
Thank you, Joost. Holger, it's yours.
Just show us what you have done in the meantime.
Yeah, basically we are wrapping up. We are about to close the groin. We were waiting, listening to what Joost was telling you. So what did we do? You saw us insert the sentinel. Then we crossed, we upscaled our sheet to an E sheet. We crossed the valve and we implanted an S323. So can we show the final result? That was our final result. What we typically have at the Sapien 3 Ultra, there is no, in the majority of cases, there is no more PVL. I think the gap in terms of PVL between surgery and TAVI using, for instance, the Sapien 3 is really marginal, has become marginal. And then basically, then it's the reverse. So we took out the Sentinel filters, and we are about to close the groin. I think I demonstrated 2 days ago ultrasound-guided MANTA closure, and so let's do that again because we had a lot of comments from participants. They were not, they were not familiar with that concept. So basically, Rakesh, if you can zoom in on the groin area. So we have our MANTA sheet. So the E sheet was exchanged for an 18 French MANTA. And we still have our 6 French sheet that accommodated the pigtail. So the pigtail is out now, and we're going to use this sheet for a final angio. A final angiographic control is essential, I believe, when using MANTA, because sometimes you have hemostasis, but you end up with an occlusion. That happens. So I think it's very important to do confirmation of your access result, of your access closure result. So, Linda, we're going to insert the plug now. So again, the MANTA is a kind of sandwich where we will sandwich the arteriotomy between a resorbable toggle anchor on the inside of the vessel and then collagen on the outside of the vessel. And there we go. So now I bring in the system, click. And we measured the depth of the arteriotomy. It was, what was it, 5, 6? 5, okay. So it was 5. So now I'm going to use my echo just to make sure that I can see the toggle. And here, oops, let me see, there you go. I'm going to pull on the sheath. I'm now at 5. And as I pull back, boof, there is the toggle. It's against the arteriotomy. And now I advance the collagen on the arteriotomy. And if all goes well, is the protamine given? Then I think we should be fine. So, 1, 2, 3. De röntgenbuis moet echt lager.
You mentioned before that you gave 5,000 units of unfractionated heparin.
Yeah.
So how much protamine have you given?
50 milligrams, 5,000 units. Yeah. And I must
So-
admit, that's
so
we
you
only
reverse-
give one dose fits all.
Okay. Because many others only give half of the units for protamine in comparison to
take it out.
unfractionated heparin.
Yeah, yeah. I agree, and especially also in the surgical literature, they are more aggressive. I am aware of the fact that in the cath lab, people are reducing the amount of protamine. I haven't seen many complications. We are a little bit less liberal using protamine in patients who require coronary revascularization, so had stenting, had recent stenting. But otherwise, I mean, this has been our practice. And this looks like complete hemostasis in the meantime. So why don't we make the angio? Because that's now the beauty of the system. We have our distal sheath in the superficial that we're going to close if everything goes well with a ProGlide. But we always have to make, watch the echo. We always have to make this confirmatory angio.
That was measured by ultrasound or by some other mechanism?
Yeah, that's a good question. So the Manta package comes with a measurement tool. And so you measure the depth with the tool because you want to follow the trajectory. So this is this measurement tool, which is nothing else than an 8 French introducer with centimeter markers. And the sheath of the Manta has that same markers. So before you enter the big sheath, you measure the depth of the arteriotomy, and you have to, of course, recall the number as you are closing. So let's briefly go to...
I guess the other beauty of this is that if there is an occlusion, you have access to the exact side to open and take care of the problem.
Exactly. So here we go. Oh, so we have to push a little bit. There's a little bit of a ooze there. So that means that we will hold pressure now for 5 minutes. And then we'll be fine. We'll be okay in principle. If not, no problem. We can insert, it's very easy then to insert a balloon through our 6 French sheath. And if we would need a covered stent, which I do not expect, then we need to upscale to 7 French. But that's very easy. That's very easy to do.
This is a really, really important
Sounds like you can.
demonstration. The reason I say it is because if you looked at the groin, there was 0 oozing whatsoever. And if you don't have a complete seal and you just say you're fine with this patient and you didn't take this picture, the patient can have hemostasis to the outside but bleed continually inside. So the fact that you're able to take this picture and demonstrate this is really important. The point I was making about the measurement issue, some people say, well, you know, if you measure before, but what if you're oozing a little bit, then your measurement later can be different. That's why also your ultrasound-based visualization of that foot plate is so really important to see, because otherwise you can get the depth wrong and inject it into the vessel or not into the vessel at all. So really nice demonstration.
So actually there are 2 ways the Manta can fail. Either the toggle does not reach the arteriotomy side because it gets stuck behind some atherosclerotic plaque, and that you can demonstrate by your ultrasound. So then you can see that, okay, it's not approaching the arteriotomy, so that is going to predict your failure. Or if the toggle reaches its side, its location, but the collagen gets lost in the subcutaneous tract, then of course you have also a potential failure mode, and that is more difficult to ascertain by ultrasound. But at least one of the 2 mechanisms is excluded if you use ultrasound. But I think I agree with you, Ajay. It is so important to make a confirmatory angiogram when using a Manta. But by extension, I use it for all closures.
But I think this is for all large bore access that we have to take a lot of attention for making sure that what looks on the outside may not be what's going on the inside. And and I think one of the other things that you showed so beautifully with the sheath down there is that you can use a balloon tamponade, hopefully, to control the bleeding, and before you would move to a covered stent, which I don't think you will need. I think you'll be able to, and I think with your showing is probably pressing down on the plug as well. So hopefully it will show us that. Well, this is a great demonstration. Thank you so much. It's truly a lean TAVI.
Yes. So I would like to thank the entire staff for a great collaboration once again, and to a nice demonstration, because of course I cannot do it by myself alone. So thank you, everybody.
Thank you. We're going to go back to the other lab.
Yes. Oké. Tommy, kunnen we misschien het finale angio service daar laten?
Ja. Ja, dat kan meneer.
Can I just ask a question about this case to Joost? You know, it was interesting on the VFR. It looked like the pullback showed that there was a relatively focal lesion. Now, obviously, it approximates a hyperemic index, but with a resting index, you can actually look at tandem disease. And I'm wondering, and maybe I missed the answer, but I'm wondering if perhaps the IVUS, which saw the more distal disease, is identifying disease that might not need to be treated in order to reverse the pressure gradient. Maybe your thoughts, Joost, on that, because this is a much longer stent than the focality of that lesion appeared.
Yeah. So I think this case clearly illustrates the fact that in patients with the BMI of 43 and a suboptimal angio quality, that the angiogram is misleading. And if you look at the IVUS, and Jürgen is now showing you the first pullback, and you can clearly see there, Jürgen, you see the lesion, which is appreciable to everybody, with the MLA of what would that be, around 1.5. But then if you go a bit more distal, you see again that you see this tandem lesion, also with the MLA very small, which angiographically at least looked somewhat bigger. But if you go a bit more distal, then you see again a lesion here. Maybe Jürgen, you can measure MLA here.
This, just for a moment.
Zit erin, hè?
And then I have another trick what I'm going to do, and that I think it's not very well known, but I'm going to try anyway. We have here an area, minimal luminal area of 2.86. And now I go a little bit more distal, and then I have here a normal part of the vessel, and then I go from media to media, 3.15. And I remember there was a paper of Hildick Ben Door, and he correlated the FFR with the IVUS. So if you have your distal reference 3.15, then your minimal luminal area before the FFR starts to be positive should be at least 3.15 square millimeters. And you see that the part in here is below that. And it was a very...
I think Jürgen, in brief, so what this IVUS showed us is that what I already was a little bit afraid of is that there is, as you already mentioned, tandem lesions, in this case at least 3 lesions in a row, over a length of almost 50 millimeters, that clearly impacted also the pressure gradient. So we didn't do a non-hyperemic pullback, but we did put in some stents in the meantime, and maybe we can look at the final IVUS.
Guys, can you flush the IVUS catheter, please, once
so this
for me?
This is the IVUS distal from the stent. Start pullback.
Yeah, no, first I want to flush. Yeah, thank you very much. Okido, now I'm going to start pullback. There we go. We pass the side branch, and you can recognize that one. And you see it's a diffusely diseased vessel, but that doesn't mean that you have to treat everything, because we have here a nice lumen. Here the vessel is shrunken a bit, and there's the stent, this distal stent, the short stent of 8 millimeters we placed there. We see that's well opposed. Don't mistake the wire for a stent strut. Here we have some under deployment due to some calcification behind the struts. We also see some overlapping struts there from the stent in the middle. Again, here we have some under deployment due to calcium. I always used to say you can push with your whole family on there, but you'll never get it round. But you see it's still a very good lumen. And in the meantime, we also passed another overlap, and here is the ostium of the MO with the circumflex. And if we finish this one, we didn't finish, we pull back, then we see that we have
So we did some. So we put it at the end 3 stents.
Yeah.
So as mentioned, the 3.5 24, then distally a trio I think was 18, and then we noticed that we just missed the distal part, so we put in another 308. And now I think, Jurgen, what we see distally is again some diffuse disease and also maybe some spasm. So I'll give some nitrates.
This is definitely some spasm, Joost. So, see?
And maybe we can pull the wire, Jurgen, because we don't see any dissections.
I didn't see any dissections, Joost.
So that is one of the key things to do the IVUS. You look at the stent expansion, you look at the distal edge to see if there are dissections, proximal dissections.
Also no dissections there. I think you can, with confidence, you can remove the wire.
All right. Yeah? Alrighty, let's see. So that looks much better. So we still see some small indentation distally. But we know there is plaque up until this very, very distally. So the question is what to do. Yeah. You see that the whole vessel is small in the IVUS. Any comments? Roxana, AJ, would you continue with another stent, or would you say, well...
I feel like you're going to keep stenting here if you keep going with more stents. Yeah.
That's what I'm afraid of.
I would like what we usually do when we see this, and especially if we think there's a little bit of a spasm, is to just bring a 2.5 balloon there at a low pressure, just distal to the stent, and then and to just inflate it for a very low pressure, almost like a massaging of the vessel, if you will. And I think that will kind of relieve the spasm if that's what's going on. I tell you though, the IVUS there showed some unopposed. I think you can stand to squeeze the proximal end of the stent a little bit more to get a better inflow. And I just think if you continue to stent, you're going to be stenting all the way down. So I would avoid further stenting. Ajay, David, maybe David could give us a little bit of an input. And Ajay, David?
Yeah. I mean, I think just angiographically, it looks as though there may be a little bit of compromise at the end of that second stent. So I, rather like you, Roxana, I'm going to give some nitrate. Take another picture. I mean, of course, having put 2 stents in, which are fairly lengthy, you don't want to leave an outflow which is suboptimal. So I think you're duty-bound to make sure that this is spasm if it is. And if it isn't spasm, well, you may be committed to optimizing that with a third short stent.
Yeah, I have a question for you. Yeah, I actually have a question for you. I mean, these are beautiful targets for bypass. I have to just say that. But I'm wondering, he made a comment about how few people are using advanced imaging. And certainly, he is optimizing his end result by really taking time to make sure that he has an excellent result. And I'm curious, in the United States, what is the barrier to more people doing this kind of work?
Yeah, it's called, you're 100% correct. I think we're doing a lot less imaging than we should be. Imaging is undervalued. And you're seeing so much more, it's so much more than meets the eye by angiogram. Maybe Ajay wants to comment on that, and then we go to David.
I'll make it really brief. I think that imaging is grossly underutilized. I think that there are a number of reasons for that. Some of it is familiarity, some of it is reimbursement. It's a variety of things. But at the end of the day, if it's your dad or mom who's having a PCI done, would you want imaging or not? The answer is yes. And then you turn around and the patients that are being treated are not getting it. So that's, I think, the way I view it. And that's why we sort of preach that we should be using more imaging, particularly now that we have data to support it.
David?
Yeah, I mean, in every survey that you ever do, everybody says, oh, yes, we'd use IVUS, oh, yes, we'd use a pressure wire, and then you actually find out the reality, and it's, only 20% of the cases had IVUS. It's a bit like asking cardiac surgeons who would use double mammaries, and everyone puts their hands up, and actually it turns out in the registry it's only 20%. So, it's difficult. I think it's time, a lot of the time for people, they're trying to get too much done it's money, and as Ajay rightly said, it's familiarity with the technology.
Yeah. Now, if there was a lesion here that I would like to have done in QFR and IFR is actually the LAD. And I see you're moving straight into stenting.
Well, the good thing is about the VFFR is that we can do it anytime. So we made the angio, so maybe we can analyze the LAD in 1 minute. Then, because I think we have 2 minutes left, then we'll show you the final result of Nicolas, who achieved a good hemostasis after 3 minutes of manual compression. So the groin is looking very good at the moment. So Ken, maybe in 1 minute, VFFR of the LAD?
I will show you. So we have got two projections, the cranial and the LSO.
Okay. Start pullback, Jürgen.
Yeah, okay, I start the pullback.
Okay, so Ken already did the VFFR here.
Yeah, we see it. It's 0.78. Let's see the IVUS.
0.78.
Yeah. Yeah, okay. So
Let's
IVUS
go
is
see the
rolling.
IVUS.
We can see the IVUS.
Okay.
So the IVUS started in the rather distal LAD.
So we have
diffuse
remodeling
disease.
there with a calcified plaque we passed. After the IVUS, we go make a summary of that. Of course, now we're going to have a pullback. Here is a lesion there with also a shrinkage of the vessel with mixed plaque, deep calcium and fibrofatty material. Again, another lesion here next to a diagonal branch. Diagonal branches in here at 1 o'clock. Here we get more than 180 degrees calcification. If the lumen is fair enough, then even you can use it as a landing zone, but probably we will choose another one. Again, here with positive remodeling, mixed plaque, fibrofatty and calcified, more proximal. And I expect in a few moments the bifurcation with the LCX. And there it is, there's the circumflex coming in, then what's left is the left main and the guiding catheter, so we can remove the IVUS. Guys, I couldn't help to hear your discussion about the IVUS and to use it or not. And if I may say so from our clinic, from all years, then we definitely see that the outcome of patients, long-term outcome of our patients is better in with imaging than if you do angiography enough. And also the matter of money, the first pullback is always the most expensive one. The next ones are always for free. So if you keep that in mind, probably it's... And here we have the lesion. So,
maybe
yes.
for the sake of time, I don't know, Ajay and Roxana, how much time do we have? Because I think we already... exactly. So maybe Tom can show the image of Nicolas, just to wrap up that case.
Before you go to Nicolas, can you tell us what you're planning to do for that LAD? Is it a double stent? So,
So as Kendra said, I mean this LAD is diffusely diseased, and I'm not so sure there are such great landing zones. And if you want, you also end up here stenting from ostium to deepen the apex, and that's what we don't want. So what I actually wanted to do is to at least to stent from on the let's say first septal up until the area where it gets a bit bigger in the mid portion, just in the mid portion where you see the small bend going down, which is a length of angiographically, I would say around 40 millimeters. So I'm going to ask Jürgen to give me a reference just before this first septal.
Yeah, that's this one here. Actually, you see here your first septal. Yes. So I think you don't want to land in this. I think this one just before the first septal is nice. You see a nice round lumen. There is some remodeling. And I have here a measurement of, with a 3.5 stent, if you bring it up to 3.6 later on, you're okay. So then we go distal, this we want to stent, this we want to stent, this definitely, this we want to stent, and I have a nice landing zone here.
Exactly.
Then the length, what you have then is, you have a 28, eh? Yeah, you had 28, I saw it.
Yeah, so I
And
mean, I
then
think you're
with a
showing us
28
a very,
millimeter.
very nice, you're showing us a very, very nice demonstration of the use of IVUS in planning, the length of the stent, the size of the stent, the landing zone, and your strategy. And I just think, and then optimization at the end. And I think it just is a very beautiful example. I know that we're running out of time, so we'll go back to, I'll hand it over to Holger, and we'll go back to Nicolas. Beautiful demonstration. Thank you, Joost. And team.
Okay, thank you.
Incredible
Bye-bye.
work.
See you in a minute.